So good afternoon, everybody. So I'm going to admit first that I've changed my talk this morning. And the reason for that is that you heard some of the things I was going to say earlier, mentioned by other speakers. So there's some objectives there which I'm not going to talk about, which is maybe disappointing to some people. So the remit was, does in-service training work? You've heard that people have looked at evidence, and Alex Rowe will speak later on a much more comprehensive overview of whether in-service training can work. So I think I will leave it to that review, other than to say that there were systematic reviews done over a decade ago which suggested that the median effect was less than 10% in changing provider behavior. The particular area that we evaluated in a Cochrane review was whether emergency care training, which is becoming more common, things like pediatric advanced life support or similar, whether they actually change real life practices, there is almost no data for, because it's so hard to get the data on what people do in emergencies. So I'll leave the discussions of whether training works, but I think the short answer to that is it depends, and not nearly as much as we might like to think. But I will tackle some of the other issues and maybe talk a little bit about where we're heading. So I think one of the problems we've had with conceptualizing training is that we think it's extremely simple. We assume that people are unknowledgeable, that we'll train them, give them knowledge, and therefore their practice will change. And it makes a great story, and it's quite easy to sell, and has resulted in massive investments. But clearly, it doesn't always solve the problems that people might not have the right resources to implement what they've just learned. There was an illustration of that this morning. If you don't have dexamethasone, you can't give it. So the training doesn't really do anything for that, and more elaborate or comprehensive interventions will tackle that. So training by itself is not necessarily very effective. Training also, we've known for some time, doesn't actually really change. It gives you perhaps the competence to do something, but it doesn't actually mean that you want to do it. And that's another big gap in our thinking about training, that just because people are knowledgeable, they will do the right thing. As we all know, drinking alcohol is bad for us, and we clearly want to carry on. And then finally, in terms of outcomes, there is, as far as I'm aware, and Alex will clarify later, extremely little evidence that training changes patient-level outcomes. So I think we've oversimplified that training is an intervention to improve practice, and I think all the speakers this morning have spoken about much broader interventions for those reasons. Maybe just to highlight some of the downsides, we don't often hear much about this, but in terms of what does it cost to train, in our experience, even running a program within a low-income country provided by good trainers from that low-income setting, it wouldn't be far off the mark to say it's $100 per day per participant. And that's probably an underestimate for some Western-run courses. With that kind of training course, a one-week training course could buy you 2 nurses for a year. So there is a significant opportunity cost of investing in apparently simple training courses. There's clearly a reduction in the workforce while everybody's at training, and if you ever go and do some qualitative work in these types of settings, you'll hear that as a familiar complaint. We can't do it because the people who are supposed to be doing that are away at a training course. And it can be demotivating because managers always tend to send their friends on training, so that the same people go to multiple trainings in a year, and most people don't get trained. And we've also used a cascade model whereby somebody goes on a course, and then after that course, they're expected to be able to train on it. Well, the educational literature would suggest that was a very poor way of transmitting effective messages, but we've used it extremely widely in health. There's also problems with critical mass, trainings where people get pulled from some place to a central location, and they may be 1 or 2 participants, and they're sent back to a facility where they're surrounded by 30 or 40 of their peers, and suddenly they're expected to change the behavior of the other 28 or 29 people. And that just simply doesn't work, at least not in general. And we have created an epidemic for ourselves in that it has been the habit in many countries, I think it's slowly beginning to die out, that people are paid to go away on training, which means that they won't change their behavior until you give them the financial incentive. And that is a major challenge, and it still happens, I'm afraid, that people literally get paid not only their costs of attending the training, but are paid to be there and sit on the desk. So the bottom line is that training is one part of a complex intervention and a complex situation, which we've all heard about. And you won't be able to read this. In one sense, it doesn't really matter. We tried to work out in an intervention that we used, which included training, but we knew at the beginning it was not just training, what it might actually take to change the day-to-day practice. And it involves everything that I think my colleagues have talked about just now and earlier, in changing the way that you interact with the senior management, how the senior management create a culture in which you can act, how you, even things as simple as how you change the layout of your environment so that people can implement the training they have. It's changing the way people practice is an extremely complex business, and that's why I think some of the interventions that work with providers at the front line are clearly going to be more useful, because they understand what it is that needs to be changed. But I wanted to quickly highlight the fact that we probably need to work a little bit harder at specifying what it is that we do when we intervene, in terms of what our interventions are. And there are a number of models, but this one I think came out a few years ago and is, I think, fairly intuitive, which just tries to partition out, when we're offering an intervention to change behavior, what it is we're actually trying to do. So this is the work of Susan Mickey and colleagues, trying to partition different parts of interventions into what they are, which level of the system they operate at. And the smaller model on the left, called the combi model, is actually trying to articulate what it is we're trying to do at the individual level, how we're trying to change that person's behavior. And we're often not very good at specifying up front about what it is we think we're doing when we're intervening, and then saying whether or not we do what we said we were going to do, the fidelity we have to our ideas of how to achieve change. And I think we need to be better at doing that going forwards. This is just our example, a quick one, of taking that combi model, but realizing actually we're trying to change behavior at several different levels, all of which interact with each other. And then interventions themselves are relatively complex. We're all operating, most of the interventions we're talking about operate at multiple levels of the system, and certainly if we're thinking about making them to scale, from right at the national level right down to the front line, and we need to be cognizant of the fact that we're different intervention components at different parts of the system, and they're probably all part of our package. So even when you have a quality improvement collaborative or using COPE, the fact that you have external people coming in from country X to partner and talk with government, that is actually part of an intervention. I think there's a central role going forwards, which has been mentioned earlier, for data. And at the moment, data do not allow us to understand what's going on in health services. There are no data, and we have to create data models, and they're created as long as the program survives, but then they go. And that's a long-term weakness that I think we all need in some ways to address, and part of that is about developing common data frameworks going forwards for things like maternal care, pediatric care, non-NCD care. We need to know what data we want, and we need to work together to make sure it's available. And I think we also need to make progress on how do we measure quality. So this is an example of some work that we're trying to do, which is actually trying to not take a single indicator, but trying to aggregate indicators across patients, across multiple quality indicators within a patient, and potentially, as patients have multimorbidity, across morbidities within patient, and get an aggregate score. And work we've done on a number of data sets suggests that if you take a quality index, it is related to outcomes. The higher your quality on an index, the better your outcome. So I think training is something simple to do. It may be necessary, but is never sufficient. We talked about context earlier. I think data and information and their availability are key to this whole field going forwards. And if this type of work doesn't invest in data, then we're just continuing a problem for ourselves. And there is also a major issue, as I mentioned earlier, about the capacity at national levels to really engage in this process and take ownership of it rather than just receive it. Thank you.
Thank you very much, Mike. We're now going to be joined by Javier from on video, or I believe.